This diagram illustrates the baseline incidence of perinatal pathology in the U.S. 1 out of every 7 birthing parents will develop postpartum depression. The pathology extends to the broader family unit as well, presenting in approximately 10% of non-birthing partners and new fathers. We have highly effective, evidence-based treatments for this condition. Yet, despite its high prevalence, it consistently evades clinical detection. Patients slip through specific structural gaps in the postpartum medical timeline, and the acute psychological distress is frequently masked by cultural expectations surrounding early parenthood. Resolving this diagnostic gap requires mapping normal physiological shifts against pathological conditions, using precise clinical features and a rigid chronological timeline. This analysis will examine how rigorous symptom tracking, reduced clinical stigma, and remote logistical care models address the physical and psychological barriers keeping patients at home. This chart maps the explicit temporal boundaries of the postpartum period. Using a strict line is the most reliable way to separate normal hormonal shifts from clinical pathology. Notice this initial curve. This represents the baby blues, a standard, transient physiological state. It peaks around day 3 to 5 postpartum and fully resolves before the 2-week mark. This sharp vertical spike near day 0 represents postpartum psychosis. It is a severe psychiatric emergency, occurring in roughly 1 to 2 per 1,000 births. Postpartum depression occupies a distinct diagnostic window. The onset typically occurs within the first 4 weeks. Crucially, the symptoms persist without lifting well past the 2-week threshold. The DSM-5 specifier extends this diagnostic recognition, allowing for formal classification of symptom onset up to 12 months postpartum. Time duration is the primary diagnostic filter. If symptoms fail to resolve after 2 weeks, you are no longer observing a transient hormonal shift. The immediate postpartum period imposes a disorienting physical and mental toll. Erratic sleep and relentless pacing create an environment where clinical symptoms easily hide. This matrix compares expected postpartum baselines against pathological features. Waking up for newborn feedings is standard sleep interruption. The inability to sleep even when the infant is finally resting indicates pathological disruption. Exhaustion is expected. However, profound fatigue accompanied by intense anhedonia and severe difficulty bonding with the infant crosses the line into clinical depression. Within the pathological column, one specific symptom requires careful triage: intrusive thoughts regarding infant harm. Clinically, these thoughts are ego-dystonic. They are entirely unwanted, deeply distressing, and strictly contrary to the patient's actual desires. Ego-dystonic thoughts are highly treatable. Their presence does not indicate that the parent possesses any intent or desire to act on them. Because they contradict the patient's identity, keeping them hidden generates immense shame. Simply guiding a patient into clinical disclosure and validating the ego-dystonic nature of the thoughts dramatically reduces their psychological burden. Clinicians must never confuse these distress-inducing thoughts with the ego-syntonic delusions of postpartum psychosis, where the thoughts align with the patient's altered reality and demand entirely different emergency protocols. Accurately identifying ideation as ego-dystonic prevents junior clinicians from triggering unnecessary psychiatric panic. It allows them to safely route the patient to appropriate outpatient therapy. Individual pathology only explains a portion of the crisis. To understand the underdiagnosis of PPD, we have to look at the structural failures of the surrounding healthcare pipeline. This flowchart illustrates the standard obstetric pair model. After birth, the birthing parent is monitored briefly, but the formal OB care track typically hits an abrupt final discharge at the 6-week mark. Simultaneously, the pediatric care pathway diverges to focus exclusively on infant weight and developmental milestones. This creates a visible clinical void for parental health. Within this void, cultural friction takes hold. Societal pressure to perform as a good mother forces parents to mask their exhaustion and guilt, preventing them from self-reporting during brief medical visits. Clinicians must actively screen for compounding physiological and historical risk factors. A history of thyroid dysfunction, PMDD, a traumatic birth, or a NICU admission significantly elevates patient vulnerability. This chart highlights severe demographic disparities. Communities of color and low-income mothers carry a much higher statistical risk burden, yet they experience drastically lower rates of clinical diagnosis. Postpartum depression thrives in the systemic dead space between OB discharge and pediatric well baby visits. Closing this gap necessitates proactive, targeted screening by all allied health professionals who interact with the family. Once identified, stabilizing and treating PPD relies on 3 pillars of evidence-based intervention. This diagram outlines the treatment model. Pillar 1 is psychotherapy. Interpersonal therapy, or IPT, is specifically validated for the perinatal population, alongside robust outcomes from cognitive behavioral therapy. Pillar 2 is pharmacotherapy. First-line medications like sertraline are safe and compatible with breastfeeding when carefully managed by an OB or psychiatrist. Pillar 3 consists of adjunct treatments. This includes bright light therapy, structured exercise, and the absolute clinical necessity of mandated sleep and logistical caregiver support. We face a logistical paradox. World-class interventions are clinically useless if the parent cannot physically access them due to travel constraints, exhaustion, or a lack of childcare. Structurally bypassing these logistical blockades requires a zero-barrier, HIPAA-compliant telehealth framework. Look at this map of Georgia. The Coping and Healing Counseling, or CHC, model provides telehealth coverage across all 159 counties through a diverse team of licensed clinicians. Financial accessibility is built into the model. Medicaid patients carry a $0 copay, while commercial insurance plans maintain low per-session rates. Delivering care directly to the patient's home between feedings and naps ensures compliance. Overcoming structural and financial barriers via comprehensive telehealth is just as critical to recovery as the clinical interventions themselves. Returning to our chronological timeline, we can see how proactive clinical models close the diagnostic dead zone. The gap between pediatric and obstetric care is now bridged by continuous screening and zero-barrier telehealth access. The clinical mandate is clear. Allied health professionals must rigorously screen any psychological symptoms that persist past the strict 2-week mark. During early patient intakes, providers must explicitly validate and de-escalate the panic surrounding ego-dystonic intrusive thoughts. You are the critical bridge between an isolated, suffering patient and the systemic care networks designed to heal them. For clinicians operating in Georgia, referring a patient to the CHC network at chctherapy.com connects them to same-week, fully remote therapy. Integrating precise diagnostic timelines with barrier-free telehealth delivery allows clinicians to identify and treat postpartum depression with high clinical predictability.